or do we realize that the adversity that they're going to have to go through out on that field should be teaching them for life? And that it's an injustice for us to not use it for something that's greater, because if it's just about playing in the NFL, those numbers are horrible. So you're basically saying, yeah, I don't really care about none of y'all, because if none of y'all are going to the NFL, versus we building men. And some of those men might have a chance to play in the NFL. Some of those men are going to get a scholarship and play football. But what we're doing is building men that will, wherever they go and whatever they do, they're going to do it like a man should.
Thank you very much.
Does that work? Man, it's Saturday.
I don't know who in their right mind wants to be opposite him. Nonetheless, moving right along. We're going to begin with our first panel, and that is essentially what is lung cancer, and it's not all smoke. We're going to have two panelists that are going to be with us. We're going to have a presentation first by Dr. Clinton Morgan. Dr. Morgan is a graduate of the University of Wisconsin School of Medicine and Public Health. He followed this with a fellowship in surgical residency also at the University of Wisconsin, and he is a thoracic surgeon. He is currently the assistant professor in the Department of Thoracic Surgery at the University of Kentucky and the Marquis Cancer Center. I'm also going to introduce our second panelist now, but you may want to sit there if you want to see things, or you can come up there in front. And our second panelist is going to be Dr. Lavora Williams. Dr. Williams is a graduate of the Union University and Medical College of Georgia, where she obtained her RN degree. She has a Master's of Nursing at Georgia Southern University and a PhD in Nursing with distinction from Georgia Regents University. She is currently the Associate Professor in the College of Nursing and Graduate Studies at University of Kentucky and is Director of Community Health Advocacy and Interventions Generating Equality, known as the CHANGE Program. She is also the Sally Humphrey Research Professorship, holds the Sally Humphrey Research Professorship in the Cancer Health Equity at the Marquis Cancer Center. And both of these people have more degrees and numbers behind them than I am going to go into. But first, let us begin with Dr. Morgan, if you'd come on up for a presentation, and then we'll have Dr. Williams. You'll come up and join after that.
Do I just advance slides on my own here? Okay. Can you guys, is this on? Well, first off, it's an honor to be here, and very humbling. Just a little background for some of y'all to know why I'm here. I was operating probably a year ago, and my scrub tech, who is tough as nails, and some of y'all know her, Tara, said, "Dr. Morgan, would you be interested in helping with some outreach? Communities of color." You guys might not know it. She, I think, knew I'm Hispanic, and you know, for what it's worth, there's a lot of issues with disparities in our community as well. I think a lot of the similar issues, barriers for people getting taken care of. So I was like, of course, Tara, I would love to. And through some emails, that's what led me to be here. I'm nervous, man. Following Chris, following our representative, holy smokes. I'm supposed to be the keynote, but oh my goodness. Very humbled by those excellent talks. And, you know, I can't compete with that story. I think that said a lot more than I'll be able to say. So that's me. That's my contact information. Bunch of cards out front. Feel free to call me anytime, email me anytime. That's the University of Kentucky Hospital, where we do most of our procedures. I want to thank AMGEN, the church here, and the HEAL Collaborative, all for having me. Like I said, it's an honor. So what is lung cancer? I try to keep this pretty basic presentation so that we can focus on what's really important. I mean, in short, it's an uncontrolled growth of lung cells, right? Those lung cells don't behave, they overgrow, they spread, and that's how they cause problems. There's two main types: non-small cell lung cancer. Feel like we should have an easier to digest name for that, but that's the most common type. And then there's small cell lung cancer. Risk factors, kind of the things most people know: smoking, age. There's a lot of others, especially pertinent here in Kentucky, secondhand smoke, but more pertinent radon, especially in the western part of the state. That's a well-known risk factor that's in Kentucky much more than a lot of other places in the country. And then family history. So the treatment spans a very wide breadth of different things, from surgery, medications, radiation, and it can get pretty complicated because those are used in combinations. So it can be overwhelming to hear about and think about it. But hopefully my talk will give you a little bit of basics and how to kind of frame this in your mind. And then, yeah, as my point was, treatment depends on type and stage. Kind of a morbid picture, but for art history buffs, that's a Van Gogh, the smoking skeleton, which I always thought was kind of prescient. Okay, so how is lung cancer diagnosed? This is one of the big important questions for us, right? Chris mentioned screening, you know, and if I had to have one topic I could pick for where we need to do better, it's lung cancer screening. I think that's probably the way that we could save the most lives in this country. I treat veterans. Lung cancer is the #1 killer of veterans. #1 cancer killer in the U.S. So this is a big deal. It's important. It's important for all of us. So early lung cancer is usually asymptomatic. Chris said it, right? Nobody, you know, a lot of people don't know they have any issue until they have symptoms. And those symptoms are usually a marker of late stage disease, stage 4. They occur from, as I wrote, from metastasis, when that cancer has grown and spread to other places. That's usually the first time people have any symptoms. That could be a cough, that could be coughing up blood, that could be a hoarse voice. And the difficulty with that is, at that stage, it's very difficult to cure things. If we can find things early stage, we can cure lung cancer. So how do we do that? Imaging is a big part of it. CT scans, PET scans. I don't know if this has a pointer. Does this have a pointer function on it? All right. So annual low dose CT for lung cancer. That's a screening test. Anyone who's a smoker, age 50 to 80, or has quit smoking in the last 20 years, is eligible for an annual low-dose screening test. Chris mentioned mammograms and breast cancer, right? Almost every woman who's of age and has risk factors will get a mammogram, right? The number of patients that should get screened with a lung low-dose CT is way less than that number of breast cancer screenings. Yet, we have to do many fewer screenings for lung cancer to save a life. That kind of speaks to a lot of complex issues, but part of that is disparities, right? Part of that is, do our primary doctors see who qualifies for screening, and do they do a good job educating them on why they should have that? So that's a huge issue. And I think if I had one point to make, this is where we can really make the biggest difference. Okay, so people will come in, they'll get a low-dose screen, or they'll say be in a car accident and get a CT scan to look for injuries. That's the main way that we're finding lung cancers like this. This is the first lung cancer patient that I treated surgically. This is a VA patient. VA, for what it's worth, has been doing a pretty good job of getting low-dose screening accomplished. This patient had a low-dose screen. They found this tumor. Just by the imaging, there's a lot of qualities of that any lung cancer doc would look at and say, that's concerning for lung cancer. So after this, I got something called a PET scan. A PET scan is, as you can see, similar to a CT scan, but it is not a lung cancer test. It's a common misconception. A PET scan is used to say, I have one suspicious spot. Are there other suspicious spots out there that I need to know about? That leads to this third part, biopsy, right? So if you just had a spot like this, got your PET scan and don't see any other spots, a biopsy of that spot would be appropriate. If you see multiple other spots, which can happen, we have to biopsy those other spots. I'm getting a little bit in the weeds, but stick with me. A biopsy just means getting a piece of that tumor, right? What is it? I tell my trainees there's 3 pillars of cancer in my mind. It's a simplification. But 1, is it cancer and what kind? 2, has it spread anywhere? That's our medical word, staging, right? Staging just means, has it spread? Those 2 are key because depending on what kind of cancer and what the stage is, that's what dictates what the best treatment is. So you gotta have all 3 pieces of that information. Feel free to interrupt with questions. So, let's say you got your diagnosis. What do? As I just pointed out, what's important to you is, okay, now I know I have lung cancer. What is my stage? Because you want to know, you want to know, how does your stage affect your treatment? So we kind of talked about screening tests, PET scans, that's part of staging. MRI scans, looking at the brain to see if there's suspicious spots of the brain. There's additional imaging and biopsies, like I just discussed. Some of the components of that, we get into genetic testing. Now, we're going to talk a little bit about that later. Genetic testing, biomarker testing, where it's kind of using the same words for both of those. And finally, like Chris said, consultation with specialists. There should be a team kind of, descending on anyone with that diagnosis, because it takes a multidisciplinary team. It takes radiologists who do these tests and read them. It takes the primary doc ordering the right tests. It takes a surgeon like me to know, can this patient potentially benefit from surgery? Radiation doctors, oncology doctors, chemo doctors. So a little bit more about staging. I apologize, it's a lot of words. It's kind of busy. I couldn't find good pictures for this. But in essence, we go from stage 0, the earliest, to stage 4. Stage 4 is advanced. The cancer spread to multiple places. Very difficult to have a cure. There's a lot of new medications and treatments that are coming into the foreground that are giving a lot of people much benefit in stage 4. And that's a lot of the focus of what are the biomarkers? Are there specific targetable mutations that we have specific medications for? I think the next slide I have up. Yeah. So this is probably some of the key information people want to know. How does stage affect me, right? What does stage mean for my prognosis? It's a complicated question, but these are kind of general, very generalized numbers that one can keep in their head. So survival, Stage 0, very high, over 90%. So stage 1, that means you have a small spot, hasn't spread anywhere. Survival is 60 to 80%. That, some people might say, well, that sounds pretty high. But when you compare that to stage 1, any other type of cancer, it's very low. It's very poor survival. So why is lung cancer so difficult? It's a question to keep in the back of our mind. That poor survival extends to these other stages, right? Stage 2, it's not even that advanced stage. 40 to 50% survival. Stage 3, 1 in 5 chance of surviving 5 years. Stage 4, less than 10% chance that you're going to be here in 5 years. It's just brutal numbers. So this information just takes me back to that point of where can we make the most impact? What's going to save the most lives? And I think that's where low-dose CT screening really is the answer. And again, if we had to have, in my opinion, one thing that we're all taking away from this, how can we get our people in to get their screening if they qualify? And then how can we support them with the information they get out of that screening? This is just a graphical representation of those survival numbers. So up here, stage 1, and these new numbers, the stages, so all 3 of these are stage 1, these are stage 2. So there's kind of subsets within stage 1, stage 2. And the reason they substratified these are because even little differences, so for example, this tumor, less than 1 centimeter, this tumor, 1 to 2 centimeters, that small difference translates into a survival difference over time. And here we have advanced stage disease. You know, this is survival over months. This is percent still alive, right? Months survival. It's a brutal disease. Yes, sir. Yeah, so this data, you make a great point. So, yes. Yep. Yep. Yeah, thank you. I mean, like you said, these are thousands and thousands of people, but it's day to day. That's what we care about, right? That's when it's you, your family, that time's precious. And I'm not going to spend too much time in my talk today about the advances in stage 4 treatment, but we're making a lot of advances, a lot of the new medications. Kind of the driving force of the HEAL Collaborative being here is, you know, biomarkers and interventions for those in advanced disease. So that's a great thing to focus on. For me, I think my point is mostly the screening, but yeah, you're talking about like on a day-to-day basis, personal level. Yeah. Yep. Yep. Absolutely. Yep. And there's talk about we got work to do, right? We got work to do, and Amen. Yeah. Yes. I'll try to paraphrase.
They saw a spot in the x-ray, and the doctor called and said, don't worry about that spot. We don't think it's cancer. So my question is, does it go from stage 1 all the way to stage 4? Does it turn that way? And then how do you know, based on an x-ray, if I should be concerned or not? Because there was no biopsy done. It's just like I looked at it, and you shouldn't worry. Like it doesn't belong there, so what is it?
There's the reason she's here. She's, whew, she's tough. This is a great question, right? So that's a hard one to answer. And that's why that team of specialists, and if you're not comfortable with what you're hearing, you can ask for a second opinion, right? Because I've had patients come to me and say, well, the last guy told me it was fine. And, you know, there's a lot of physicians are humans, right? We all...
Since you brought that point up, I want Dr. Williams then to comment in terms of from the health equity standpoint. Not everybody has those options. And if you don't mind, since you invited us, you opened the door,
yes.
It's open. You're talking screwed.
Absolutely.
Okay.
Yeah, I think Chris said it well when he talked about the relationship that his wife had with her provider. A lot of times when people of color are being seen by their provider, we know that implicit bias is a part of it. And the literature speaks to that we simply are not heard, especially black women. So that is a big part of that, and learning to self-advocate, knowing when to say, I hear what you're saying, but I'm not comfortable. And like you said, it's not supposed to be in there. So what is the plan? If I trust you, when are we going to look at this again? Because it's not supposed to be in there. Yes.
Yeah, and I think just to trail off that, if you got a spot that's not supposed to be there, they can tell you don't worry about it, but in my mind, they should tell you what they think it is, right? So if you're telling me you're at a spot I don't need to worry about, what is it that you think it is that I don't have to worry about, right? So if they can't answer that.
Okay. Can you speak to an incidental nodule clinic that, you know, based on getting a checkup where you didn't go in there to, you know, thinking it's lung cancer, and all of a sudden there's a spot. Yeah, you know, with a lot of the health systems, they have an incidental nodule clinic where now you go into a system, so they're following it, and they're going to schedule a CT a year later, or based on whatever the makeup is.
Absolutely, great question. So just to paraphrase, someone gets a CT scan like I was talking about at the beginning of the talk, maybe after a car wreck, looking for injuries. They see a spot in the lung, unrelated to the car wreck, but should there be nodule clinics? How do we do that? That's a really tough question. Clearly there should be a mechanism to follow abnormal findings on the lungs, right? And that extends across outside of lung cancer, right? You got a spot on your pancreas, they saw. You got a spot on wherever. So tracking incidental tumors, nodules, lesions, that's a tough problem. And I would say that varies from hospital to hospital in how they set that up. So there's not a system. Maybe that's a problem.
I can comment on the Q&A component because we have one. So when we get to that part, we can talk a little bit about
Yeah, no,
our
I'd love to
system.
hear your thoughts on that.
I think we're going to have Q&A as this goes on. So,
I'm hoping to get
in
off
fact,
the
I
stage
think
pretty
that's
soon.
going to be. And since you brought up the thing about nodules, you have to ask the question then, those of us in Kentucky, because we have Ohio Valley
Yes.
lung disease, and then with the coal mining, and then, so how do you
Yeah,
got it all?
that goes to exactly the representative's question. So if you're told you have a nodule, you should be told an explanation for the nodule, at least a couple. It could be this, could be that, could be that. So almost every patient I see with a new spot, that's my discussion with them. Here are the things it could be. I can't tell for sure. Here's your options if you want to find out for sure, or if you want to keep a close eye on it. But you should have some explanation for what could that nodule be. And you're talking about common fungal infections in the area that cause nodules. Okay, so it's a brief single slide on small cell. Small cell is a very aggressive cancer that has a little bit less association with smoking. So this is one where you may have said, you know, they never smoked a day in their life, yet they still have lung cancer. Sometimes that's a small cell. It can be non-small cell as well, but it's a tough disease. Tends to spread to multiple places rapidly, tends to be difficult to treat. So another busy slide. This is, I'm not going to go through this point by point, but what are lung cancer disparities? I think a lot of us have a general sense for what that is. And just one general comment. We have work to do, right? That means some of this is on us, right? Some of our disparities, you know, I'll speak for Latino community, some of that comes from within our community, right? They're almost, for lack of a better term, kind of self-inflicted disparities, right? There are things that we need to be aware of. Some of that's education problems within our community. But there's also some cultural things that keep us from getting access and treatment that we need. A lot of the other heavy hitters on here, things that you all know about, you know, socioeconomic factors, geographic, racial and ethnic, healthcare system. Let's see, stigma, right? It's lung cancer related to smoking, so that means I caused it. That's a stigma that can limit people. Lots of other things. So we have multiple fronts to work on.
On the stigma component, you know, one of the key elements of kind of destroying that argument that they did it to themselves is in 1998, the cigarette industry got indicted for essentially $245 billion, saying that the people were victims of the industry rather than they just did it to themselves based on choice.
Absolutely. But I think on a personal level, a lot of my patients at least, I'll hear them still say, well, it's my fault. And I say, it's not that simple. Yeah, yeah.
Before you move on then, on that stigma thing,
Yep.
Dr. Williams, I know you have a comment about that.
So stigma, yes, it exists. So you all know when a person gets breast cancer, we gather around them, we pink out, we go do an October breast cancer awareness walk. You know, we circle them with love. It's opposite for people with lung cancer because there is a stigma associated with tobacco use. And there's also a stigma associated with a lung cancer diagnosis. If a person gets breast cancer, no one says next to them, well, what did you do? Person gets breast cancer. Oh, did you smoke? How much did you smoke? So there's this association with lung cancer that the person with lung cancer somehow deserves it. So that affects whether people will get screened. It affects whether they will undergo treatment, because sometimes there's a belief within that individual that they somehow deserve this ugly diagnosis of lung cancer.
Before leaving that topic then, you also have to address, because sometimes it's not things that we ourselves do, but talk to us about the relationship then with pollution in lung cancer in terms of either being a primary etiological agent or exacerbating a risk, but there are other risk factors that we may have.
Yeah, that's a broad topic, but obviously environmental toxins, pollution has some effect. Radon, yeah, we talked about radon earlier in the talk. We know those things are real, but on an individual basis, it's very difficult to say, I have lung cancer. Oh, it was caused by when I lived in the basement in Western Kentucky for those years, right? It's very difficult to know and to pin down precisely how those environmental exposures cause
But
cancer.
the real disparity here is in the western portion of Louisville, because of Rubber Town, there's a much higher concentration of exposure to environmental pollutants, including the small little parts, 2.5 per million, in addition to other things. And I think that's where. Another question for you, sir.
Sure.
On that same topic.
What do you say to the patient that maybe says, I don't want to do a biopsy. I want to pray about it, change my diet, exercise more, keep an alkaline kind of environment, eliminate, you know, all the bad things from my diet and my environment. How do you proceed with that kind of challenge? What do you even say? And do you say, try it your way and then we'll try it my way, or?
That's an amazing question. I wouldn't have thought to bring that up, but I get that question frequently. And my answer to that is, here's my job. My job is to tell you, to the best of my knowledge, what I think you're dealing with. It could be X, Y, and Z, right? Here's what we could do to figure it out. If it was X, here's what the treatment could be. If they tell me, okay, I understand that, I don't want to do any of that, I say, that's your choice. You have autonomy, right? You can make your choice. My job is to give you the knowledge that you can make that choice for yourself, right? So if you know what those options were, you don't want to do them, that's okay. That's your choice. Yeah.
I'll bring the microphone to you
one
just
more,
1 second.
One more point on that
please.
topic. The other key thing I tell them, if we're dealing with a single small spot, and I think that's a cancer, I make sure they know, okay, you can wait, we can try to watch it, but it's unpredictable, right? So at some point, it could go from a curable spot that I can take out to multiple spots that we can't cure. And you need to know what that means for your prognosis. Does that make sense?
Okay, just
Yes,
going
ma'am.
along those lines, do you ever collaborate or bargain? What I'm trying to say is, can they do the medical therapy and the alternative medicine in concert?
Yeah, I have patients. If that's what they want to do, you know, I try to respect their wishes, and they can do what they want. I can tell them my opinion of how much, you know, I think that will help, and what I think is kind of the standard treatment. I think I have 1 or 2 more slides, so let me power through those, and then
You asked for
we can have our.
questions.
I did ask for questions, and I love the questions. These are great. Okay, disparities, we covered that. How do we address disparities? So, again, huge question, right? You could talk for 2 hours on this topic or have a whole symposium. But policies, right? So we were talking about policies earlier. That's a key component. Increasing awareness, education. That's part of what we're all here for, right? You know, like I said, I'm honored to be here, but I'm also working. I want to be out there, make connections, right? This is a community. I'm a person, right? Livora's a person, right? We care about patients. We care about treating people. So I do this because I care. Promote cultural competence. I think that's another component of things like this today, right? Health insurance, I'm not going to tackle that, but I think we all can appreciate how that would be important. Social determinants, poverty, housing. We were talking earlier before the conference, how do the social, like on a day-to-day basis, some people aren't seeking out diagnosis and treatment because they don't want to know the answer, right? If I get a bad diagnosis, then I'm not going to be able to feed my family, right? So education on getting a diagnosis, maybe stage 1 diagnosis we can treat. You can take care of your family for 30 more years instead of 3 more years, right? Those are big questions. And then again, this multidisciplinary care team, navigation programs, that reiterates a lot of the questions we talk about. How do you follow a nodule that's incidentally found? who needs to know when a new lung cancer diagnosis is made, who needs to be at the table for that discussion. Misconceptions. I think this may be on my second to last slide. So I don't know if any of y'all have heard this. Air got to it. I'd never heard that in Wisconsin or Oregon, but I hear that probably 1 in 5 of my patients ask me about, okay, if I'm thinking about surgery, is the air going to make it explode? Can I raise a hand who has heard this? Okay. It's a very prevalent belief. You know, there's no data behind that, and I'm going to diverge a little bit and tell you guys what I tell my patients. There's 2 reasons I think this is wrong. One is, in the old days, when people got a lung cancer diagnosis, they see a big spot on the x-ray. Why'd that guy get an x-ray, or gal? They had a hoarse voice. They coughed up some blood. Something's not right. You go get an x-ray. There's a big spot. Well, what did we talk about at the very beginning? People don't have symptoms from lung cancer till it's spread everywhere, generally speaking. So they get an x-ray. They don't have these fancy CT scans we have now. Doc says you got to get that cut out, right? They go to the operating room. They open you up. Well, lo and behold, there's spots everywhere. But to the patient, it was just in the one spot till the doc opened me up, right? So I think that might be part of that. The other thing I tell patients, if you think about your lungs, what do? They're more air exposed than our skin, right? And the tumor is within the lung. So even when I open you up, that tumor is not getting touched by the air of the surroundings, okay? So that's what I tell my patients when they are worried about the air got to it. Lung cancer only affects smokers. We talked about that, right? That's a stigma. That's a misbelief. Only older people get lung cancers. Chris, that was a heart-wrenching story, and thank you for sharing it with us. Like I said, that's hard to follow you. But that's important, right? You can get it when you're younger. So 50 is pretty young, right? If you're 50 and you're smoking or you recently quit smoking, you should probably get screened. Lung cancer is always terminal, right? This idea of fatalism. If I get a lung cancer diagnosis, that's it. That's the end for me. Well, we can cure a lot of it. Even some patients we can't cure, we can get a durable survival response. You get precious days with your people. No symptoms, no problem. I think I already talked about this a few times already, right? Self-inflicted. Again, there's that stigma. I caused this problem, so, I'm to blame. Treatment worse than the disease. I didn't really talk about this too much. Probably don't have time to delve into it, but that air got to it. It kind of exemplifies one component of that. Maybe the treatment's worse than the actual disease. Prevention. I'm not going to address that too much, but smoking cessation programs, aware of environmental factors, those things can help. So I kind of tied this screening thing, and I think I beat it pretty good into my talk, but again, that's why this is my last slide. Hugely important thing, and in my humble opinion, if we had to do one thing, it'd be focus on this screening. Yeah.
Misconceptions.
Absolutely.
I always feel like we're saying that somebody doesn't know it, but it's based on what our community told them, right? Rather than realizing that we are just not doing a good enough job of telling people that anyone can get it. I'm saying in terms of the stigma that literally we have the best argument to destroy stigma, and we've had that since 1998. We just haven't used it. So we're letting people get blamed when we prove that it was already somebody's fault to the tune of $245 billion, right? So lung cancer only affects smokers. We don't say that, right? When I went to American Cancer Society in March of 2011, even though my wife's 37 years old, the first thing they said to me is Great American Smokeout, right? So I say to somebody, if that's all they knew, well, that's because that's what American Cancer Society said. The other one is if somebody's blaming themselves. CDC's tips from a former smoker literally has a person who stopped smoking say, I was wrong. And they're showing somebody that actually had early detection, had surgery, and they're showing that as a failure in the commercial. So again, a lot of my work has been basically just saying that if we want to educate people, what do we need them to know? And are we actually saying it and making it clear and going to the people based on the fact that we actually taught them something else? So before breast cancer had awareness, there was no awareness for breast cancer. But we've had an awareness of a connection with smoking since the Surgeon General said that in 1964.
Yeah, that's a hugely important point, right? I think on a medical, platform, we're somewhat aware, but that's not getting translated to the public, right? That breast cancer awareness, that got translated. I haven't really, dedicated time to thinking about why the breast cancer campaign would be successful, but our lung cancer education isn't. I'm sure Lavora and I'll bang out this slide, and then, I'm sure you could talk at length about that issue. Screening. This is just kind of reiterating those guidelines. Age 50 to 80, right? This was recently extended from 55 to 75. Doubles the number of candidates that are screened, that meet criteria for screening. Yet, the screening hasn't doubled, right? So, people aren't being screened. Smoking history, 20-pack years or more, or current smokers, or smokers that quit within the last 15 years. That's pretty simple criteria. We should be able to identify those folks, and your primary doc should know this. We should know this so we can ask for this. And then finally, shared decision making. You gotta find someone you trust. You have to have someone you can work with to help guide you through this path. And that's, to some extent, that's going to be providers, but to some extent, that's us, right? Thank you so much for having me. This is my family. They've been super supportive, and a lot of hard work and long hours, and me taking time away from them to be here, places like this. So.
Dr. Williams, why don't you come up front? Keep that with you. Let's see. We have a few minutes left for some questions, but Dr. Williams, I think you had a comment that you wanted to address, particularly as related to, well, let me ask you, if there was something you wanted to say. I saw you jotting a note to yourself, and I didn't know when that, because if not, I want you to go through the process of where we are once that person gets screened, what happens to them after that, so that we don't lose track of that individual.
I think that's a very good question. And we touched on it a little bit. So there are lung cancer screening programs that are screening programs of excellence. And those programs not only screen individuals and take them through the shared decision-making about their screening, but they stay connected to them. So it's not like a one-and-done thing. So an individual who gets lung cancer screening should be rescreened again in a year. Those lung cancer screening programs that are centers of excellence have what's called nodule clinics. So what happens within those clinics is sometimes after lung cancer screening, there's a nodule. It doesn't look like cancer, not sure what it is, but we don't want to lose that patient. So that patient becomes a part of the nodule clinic where they are followed up on a certain timeline so that they're not lost to follow up. So those are some of the things that are important within the lung cancer screening. Is not think of it as just a one-time thing and it's over.
Okay. Dr. Morgan, you work in a VA, which is a fairly controlled medical insurance setting. So your population may be a little different, just wondering. In Kentucky, we have a high number of people who are on Medicaid, particularly when you look at expanded Medicaid coverage. Is cost a factor for people getting screened and then subsequently treated? And Dr. Williams, I want you to address that also at the Marquet Cancer Center. If someone is diagnosed, should money be, or lack thereof, be a block to someone getting their care?
That's an excellent question. as you mentioned, the VA system, it's a little bit of a controlled environment, for lack of better words. I think in that setting, at least my experience in this system, the primary doctors do a very good job of at least recommending and offering. Whether we can do a better job of discussing a patient's decision not to undergo screening, that's a big question that's probably hard to answer. But with regards to the cost of screening, a great question. I think that is a barrier. I think Lavora may have better insight into that, since it's something that she's delved into a little bit more.
Dr. Williams, what do you think?
Dr. Morgan touched on it a little bit in his presentation when he talked about the costs and what it means policy-wise. So thankfully, years ago, the Center for Medicaid Services did pass the policy that insurance and Medicare does pay for lung cancer screening. And now most private insurances will pay for lung cancer screening. In addition to that, given that lung cancer screening is a relatively new screening procedure, some centers even offer lung cancer screening at no cost. So there still is an access issue, but there have been some measures put into place to overcome that.
So, Dr. Morgan, similar to probably what you see, and you can expand in our African American population, and maybe in the Hispanic, we often hear, "Oh, I'm not having surgery; nobody's cutting on me." But can you talk about, if you have a small nodule, how sometimes surgery could be both diagnostic, curative, and more cost-effective?
Absolutely. Excellent question. I thought you were going to take that in a different angle with the radiation treatment for SBRT, so I'll try to remember to tie that in. Again, my kind of leading drive is respecting the patient's decisions, but ensuring they know what they're looking at, or at least know what the main possibilities are. So if it's a high probability lung cancer, I'm pretty sure it's a lung cancer, I will tell them that. And I'll say, if they tell me no one's cutting on them, I say, that's fine. No one's trying to force you to get, a treatment you don't want, but please tell me why you don't want surgery. So about 75% of the time, the answer to that is the error is going to get to it. So that's understanding what the barriers are, what the misconceptions are, and addressing those. And probably out of those 75% that didn't want surgery because the error would get to it, after I give them the explanation I gave you guys, probably about 80% of those are like, that makes sense, I will consider surgery. And a lot of them do end up having surgery. To get to your point about the cost and efficiency, I do often discuss what would a surgical biopsy entail, right? And what are the risks, benefits of a needle biopsy? I don't want to spend too much time, but I tell them a tumor in relation to a small needle, right? It's a big tumor, small needle. So if I poke that tumor with the needle and see cancer cells, well, that proves there's cancer cells there. But you can poke that tumor, not see cancer cells in the needle. That can't prove there's no cancer cells in the rest of that spot. Sometimes that leads to a discussion of, okay, well, we could do a surgical biopsy. I take out the whole spot. We look at the whole spot under the microscope, often while you're still asleep. And if it's cancer, we can do a cancer operation at the same time. So that appeals to a lot of people. And then the final point, for small nodules, patients that absolutely refuse surgery, or patients that aren't able to tolerate surgery from other healthcare, other comorbidities, we'll talk about radiation treatment. I call it spot radiation to the lay people. Basically, that's SBRT, which has a not as good as surgery cure rate, but it's got a cure rate, probably around 40 to 60%, depending on size of nodule. So that's a good option for a lot of folks.
Though there are admittedly multiple things that can give rise to the development of lung cancer, still, unless I'm wrong, the number one thing is smoking, be it primary, secondhand, or tertiary smoking. So is this still the message that we have to get out? That the number one way to prevent to prevent development of lung cancer is what? What do you tell people?
Tobacco cessation and never starting. So what I say to my patients, no matter how much or how little they smoke, is that there is no safe dose for tobacco use, and that the best thing they can do for their health and the health of those around them is to quit smoking. And then I tell them how hard it is. It is hard. Nicotine is a very addictive substance, but there's evidence-based treatment for nicotine cessation. And there are programs available for individuals to undergo it. And the best way is to combine the medication with the behavior therapy, where they're taking the medicine and also going through therapy to learn about those things that are associated with that cigarette in their coffee, that cigarette when they're stressed, that cigarette when they come home from work. So we have to also break those connections to the cigarette, and that's where the behavior therapy and counseling comes into play.
Well, I want to thank you all. This has been a rather different presentation and panel discussion. Dr. Morgan, I admire your bravery for opening up questions during the middle of it. But I want to thank both you and Dr. Williams for providing answers on the cuff, if you will. But thank you both very much.
Thank you so much.
That was a little interesting for me. Our next panel member is a survivor. We have heard from the providers, but now I think it's time that we hear from someone who has been through the process. We have with us today Ms. Cindy Stallard. She is a 12-year lung cancer survivor, and she will share with us her story. Ms. Stallard. May I just say one thing before you?
You sure can.
We will take questions after the presentation.
And I'm going to keep it very, very simple. October 5th was the day I received my diagnosis, so I will be having an anniversary pretty soon. I was diagnosed at stage 3B inoperable. I went through very extensive, aggressive, I guess would be the word, radiation and chemo. And the cancer, that I was diagnosed with a mass in my left lung, and it had spread to my lymph nodes. The way I came to know was that I went from working with women in an abuse from a domestic violence facility. I worked in a facility for women and children, and I started out in intake, but then I just loved the kids, and I knew they needed special attention, and I asked if I could move to working with the children to help them implement safety. So I wanted to plan all kind of activities and things. But when I started working with these kids, I don't think this is a myth. When you work with kids, you get germs and sick. So I caught a cold. But I thought it was just a cold. So I kept going and getting steroids, and finally they got to the antibiotics. One day I tried to plan an activity with the kids where we were playing kickball, and I attempted to run, and I thought I was just going to keel over. But this cold was not going anywhere. I went to the ER. They detected the mass, and so on and so on. And that brought me to getting the diagnosis of having a mass having and it being cancerous. So now the rest is history. Here I am. Recently, I have a doctor that I trust, and I trust all my doctors, even the one that used to. That's another part of it. Dr. Wayne Tuxton was my doctor, in 1994, because I battled Crohn's disease. And he was the doctor that got me to that, because in 78 I was diagnosed with ulcers when I believe then it was really Crohn's. And I don't want to get off track, but I trust my doctors, my oncologist, my colorectal specialist, my radiologist, all of my doctors I trust. And I think that's something that the community needs to understand, because in our culture, in the community, that's not emphasized enough, I think. And that can be one of the things that's implemented or encouraged, I'll say, to get people to get past some of these health scares. But anyway, I went through the chemo radiation, the cancers, the mass has been caged in. It did reduce the mass, and here I am. So, and I'm grateful. Okay.
I'm great. I got to do something for you, I've been told. But before I do that, one of the things, if you would comment on, I'm not violating any HIPAA law since you brought it up. You are one of those who ask questions. So do you think that there's some patients who are not very participatory in their care by becoming engaged? And how do you tell your friends to become so? To get engaged in care? Ask the doctor the question.
I've encouraged people to ask questions mostly because of my sharing my experience. I'll just say it that way. My experience is to trust your doctor, and if you don't know, write the questions down. If you can't remember, because most people may sit in one part of the day and think of this, that, and the other, but then get to the doctor's office and can't remember. So I've always encouraged people, and I work as a caregiver, even with some of the people that I care for, which are usually in the older age group, like 80 and 90. Even I write questions down for things that may be going on with them, so I can remember what to say to their doctors if their family's not present.
Yes, ma'am.
So that would be one thing I would say.
Yes, please.
So I have a question about engaging our communities and why we don't make health or this type of information a priority, okay? Because we talk about other things in our community and people turn out. And what we've experienced as an organization is when we talk about bringing these types of programs to the community, we're trying to educate, not just have a health fair. We're really trying to help us understand what diseases are and what they're not. I mean, from the basics all the way to, all the new advances in medicines, testing, screenings. And we always get this response back, well, what about prevention? We can't get people out to even talk about prevention. Mm-hmm. What you said, Dr. Williams, about stop smoking, that's prevention, right? It's what do you think it needs to take for us to make our health a priority?
Oh, that's the $1 million question, and I wish I could answer it. Dr. Tuxton could probably, or Dr. Williams, or somebody could probably answer that, because I've wondered many times. I lived in an area, at one time, I lived in Western Kentucky. I've heard so many things said today. I lived in Owensboro, Kentucky when I got my diagnosis. That's Western Kentucky. Prior to leaving here, this city, I lived on Northwestern Parkway, Rubbertown. So I was a bartender for a lot of years, exposed to secondhand smoke. I don't know. I wish I knew. I wish I could answer that. Can anybody else answer it? Because I can.
I think the answer to your question is multifaceted. It starts at home. It has to become a part of our culture to talk about healthy lifestyles and not just getting by and grinding and making things happen. We have to talk about healthy lifestyles, healthy nutrition, physical activity, taking care of our temples. And then it also needs to be transmitted to our schools, to our church, so that organizational level, and then policy. There has to be policy put into place that dictates sidewalks in our neighborhoods, tracks in our neighborhoods, access to care in our neighborhoods, so that it makes the healthy choice the easy choice. A lot of times we have to go all out yonder's back door to get what we need to stay healthy. So a lot of different multifaceted approaches is what I think needs to happen. I want to give a shout out to St. Stephen's. My work is diabetes prevention, and St. Stephen's was one of my research churches. We recruited very well here for diabetes prevention, and our coaches were awesome. So there is a desire within the Black church to be a part of that movement for health. So it's hard, but we just got to keep at it and just not grow weary with what we're trying to do.
I knew she could answer that question.
If you think they do a good job of that, you should see what Dr. Gaither does with stroke and stroke prevention. That's something you might want to talk about. Well, Ms. Dowd, thank you very much. We appreciate you sharing your story. It's always good for me to see you. Mr. Draft has something he wanted to present to you. Nice, because you're getting it from him and not me. That's what you're saying. No, she don't.
Thank you so much.
The first white ribbon was made in Greenwood Village, Colorado. It was made a little over 3 years ago. It was September 27, 2020, and Heidi Honda, a survivor, she was asking what the local cancer center was doing for awareness. You know, we have all these things that we need to address, and they didn't have a plan. And so she finally got mad, and she asked her husband, she said, "Can you make me a big white ribbon?" See, there was something else inside of that. And he went out in the garage, and he made it, cut it out for him. Every ribbon that we make is traced from that
Ridley.
one of those original ribbon, right? And you always trace it, and it reminds us that each individual person matters, right? And that what we can do, what we can control, is loving our people. Yes. All right. So when we say that you know, breast cancer, that they get rallied around, we just have to choose to rally around our people, and that's what the White Ribbon Project is about. It's saying there are things that we can control, and so if somebody feels like they're alone, all we got to do is just make sure they don't. There it is. That's a choice.
Thank you very much.
That's a choice. Thank you for sharing.
That is a remarkable story. Finding out so much today. It's just bloody amazing. Just really amazing. We're going to move on to our next speaker, and it's Dr. Eric Flanault. He's Associate Professor and Vice Chair in Department of Medicine at Morehouse Medical School. You know, if you can't be at Howard, be at Morehouse. He's also the Chief and Director of Pulmonary and Critical Care, as well as Interventional Pulmonary Medicine at Grady Hospital. Dr. Flanault is a graduate of the University of Texas Health Sciences at the McGovern Medical School. He also did his residency and fellowship in pulmonary and critical care down at the same institution. Also, what I like to point out, once before I had a chance to introduce him, he's a cover boy. He's a cover boy. Because he was on the cover of Atlanta Magazine as top doc. And so we are in tall cotton right now. Dr. Flynn.
Let me take this out. Yeah, let me take this out. Oh, it's just child-proof. Okay. Got it. Click. Well, that's the good-looking guy. Yeah.
Did somebody turn on the heat, please?
Wow. Okay, click it. What I do? Wrong one. Okay. Got it. All right. And the pointer is the thing up here. Okay. Oh, that's a good color. Okay. I'm going to talk a little bit about biomarker testing. We hear it a lot, and sometimes people just don't have a good understanding of exactly what it is and how helpful it is. So I will run through some of that, and why it's helpful and important in the lung cancer diagnosis and treatment strategies. But I do like to go back and sort of reiterate what we've already heard today, go through some of the untold truths and the realities about lung cancer, especially in our patient population or in our population here, our community. So targeted African American men especially, but African Americans across the board are at highest risk of developing lung cancer, even though they may have smoked the same as other populations. They have the lowest likelihood of being diagnosed on time or in an early diagnosis. They have the lowest likelihood of getting curative treatment. They have the lowest survival rates, and the men are at most risk. And so we talk about, and we've heard this about prevention, and whatever else. It's never too late to quit. It's always too early to start. Okay? All right. And Dr. Morgan, he did talk a little bit about the screening. This is very important, very key. The criteria did change, like he said, to try to increase the number of people that would be candidates. It was specifically moved from down to a lower age, from 50 to 55, to catch more African Americans, because they found that African Americans were not benefiting from screening as much as the other patient populations. Okay, you can be a current or former smoker. If you quit any time within the last 15 years, you still you're a candidate for screening. And at least, like he said, a 20-pack year tobacco use history, which is, if you smoked 1 pack a day for 20 years, that's 20-pack years. If you do the math. If you smoke 2 packs a day for 10 years, that's 20-pack years. And there are people that do that. So keep that in mind in terms of the criteria. And if you fit in that criteria, or if you know somebody, let them know that they should get considered for screening. Talk to their primary care doctors, because it does save lives. More untold truths. We talked about smoking. And the thing that I put this following those calculations, because people really don't understand the differences. And I want to get this across. Okay, so nicotine, very, very, very addictive. If it were to come out today, the FDA would have a hard time getting this through, because it's very addictive. The problem is it's so ingrained in culture and politics that there's not very many limitations on it. But a cigarette, it's not only nicotine that's causing the cancer, it's the other things that come along, but the nicotine keeps you going back for more, okay? So a cigarette has about 8 milligrams of nicotine in it, okay? Now what I've started to hear, and when I talk with our patients, it's not just asking how much they smoke, it's what do you smoke, right? Because as, people tell me, well, I only smoke 1 or 2 a day. Well, it's not that. They're talking about, the Black and Milds, okay? And these are the small cigars. Well, those can have up to 100 milligrams. So you're talking about 12 to 15 cigarettes in one of those, okay? And so this is the thing. The tobacco companies know this, and they know who they're marketing to, okay? And people think, oh, I'm cutting down because now I'm not smoking a pack. Now I'm just smoking 1 or 2 of these Black and Milds. Okay. Why do you think they named it Black and Mild? Okay. Okay. And then the large cigars, and it's cute. You know, they see them. You win a football game. I'm smoking a cigar. I'm smoking a cigar. Okay. That's up to 200 milligrams. Okay. About a little over 20 cigarettes in that one time. Okay. Or what's the new trend, right? The new trend is the hookah sessions. Okay. And it's, oh, we're going to hookah bar. And I've seen this, especially in the African-American communities. The hookah bars, and it's good, profitable, and whatever else. And you go for like an hour a session, and everybody's passing around there puffing. There's about 200 puffs per person per session, which turns out to be about 100 cigarettes per session, okay, in terms of the nicotine content. Okay. And this one. So I used to do this talk, and this always came up. So that's when I learned I need to ask about not how much are you smoking, but what are you smoking, okay? Because, well, I don't smoke cigarettes. So they don't consider that because that's what we've all been told and learned to, learned and told to ask is how many cigarettes. What about cannabis? Okay, so there are studies, okay? And if you are a heavy, and I highlight heavy cannabis smoker, then you have a 2-fold risk of developing lung cancer, okay? So now the question is, what's heavy? You ready? Okay. If you use more than 50 times in a lifetime. I have patients that can't get through 50, can get through 50 in a week, right? And I'm serious. So, and this is what people don't understand because it's not filtered, it's self-rolled, and this is just assuming that they're rolling it the same size as a cigarette. And they're rolling them fat sometimes, and we've heard that. And I have to ask the patients, not only how fat are you rolling, oh yeah, I've rolled it pretty fat. And what are you rolling it with? Are you rolling with the paper? Are you rolling with the tobacco leaves? And how are you doing? Okay. So 50 times in a lifetime put you at a 2-fold risk of developing lung cancer. And this is what we need to get out to communities because you have legalized marijuana, right? And you just pushed it one other direction from there, okay? So prevention, right? Always too early to start. Let's talk about our kids, okay? This is middle school. Middle school numbers of current tobacco users. And look at this. Overall, any tobacco product, about 4.5, about 5 students out of every 100 are using some sort of tobacco product, okay? And it's been, bubblegum flavored, we were talking about this earlier, bubblegum flavored electronic cigarettes, okay, or straight cigarettes, some cigars, tobacco. But this is the high area up here, especially the electronic cigarettes. It's easy to get to, but anything. We used to think, though, okay, the boys are the problem. But look what's happening with this trend. This is middle school. Okay. And the thing about this that we realize how important it is when they're young, when their minds are young and more susceptible to the addictive properties of nicotine, how easy it is for them to get addicted. Because once they start at that age, and then that emotional thing, I'm getting away with it, okay? They move on to high school, and the numbers just keep going up, okay? And there's these electronic cigarettes, because now that's the cool thing, and they can get away with, and they don't smell like tobacco smoke when they come home. But what they realize is that becomes expensive. And over time, they just move on and start smoking cigarettes. And for the tobacco companies that started making these electronic cigarettes, say, oh, it'll help you quit. No, it doesn't help you quit, right? Because each puff, you see a big old cloud of smoke and whatever else, so getting a whole bunch more nicotine in one puff. But what it becomes is expensive, and what they eventually do is go back and start getting cigarettes because it's cheaper. If you think $10 a pack is cheaper. So what we need to realize in terms of prevention, we can't preach something to our kids if they see us doing something else. It doesn't matter what you say to them. When they see you doing something that you tell them not to do, what are they going to do? Gotcha. Okay. All right. So remember, African Americans, African American men, we need to focus on never too late to quit, always too early to start. All right, let's get into biomarker testing. And when, what is it, and when is it helpful? So we talked about this, and Dr. Morgan did explain this extremely well, okay? So lung cancer is just your normal lung cells, and something triggers them in the genes, in the makeup, that gets them to start growing out of control. And they start growing and doubling and going, and when they do that, they take over other organs. They take up the blood supply, and they kind of starve out these other areas. You see, and these changes in the genes, they're called mutations, and we'll talk about this, and these mutations are what cause this whole process to continue. And even as they continue on and they grow, you get more mutations and more changes, which cause it to help its cancer spread, build its own blood supply, and wreak havoc around the rest of the body. And so these are the driver mutations of lung cancer. These are changes in the DNA that make it grow out of control. And then what it will do is when it's grown so large, it will generate its own blood supply. And then it steals the nutrients from the rest of the body, and that's why you see people start to lose weight. They lose a lot of their appetite. They lose their energy level. And then these mutations continue on, and they help it spread. There's activating mutations. They cause uncontrolled growth. I want to tell you this specifically. You heard it mentioned, and you don't have to remember all the exact names. But if you ever hear KRAS or EGFR, they're looking for these specific mutations because there's newer treatments available, especially for those that will improve the survival over standard chemotherapy and radiation. So there's a cancer genome atlas, and they looked at 1,100 lung cancer patients, and they noticed that absent from this, were African Americans. Only 83 of the patients were of African American descent. Okay, and so what that creates is the lack of information about African Americans and how they would benefit from some of the treatments. So we know about studies, and we can do a whole talk on this, and you'll probably hear about this later. This maybe in your part 2, but you'll probably hear about this later about how our population has not participated in a lot of the studies for lung cancer, for a lot of healthcare related diseases. And the problem that creates is the information that comes out of these studies, since we weren't in the study, the benefits aren't reflected in our population. And so we get missed or we get left behind. And we've seen this. We've seen this even with the screening. The reason they had to change the screening is because African Americans were being left out. Because even though the population has about 14 to 15% across the United States are African American, only 4% were in that study. So the information, the data they got when they set up the guidelines were geared to the 96% that participated in it. Okay? So as we move along, if there's an opportunity for biomarker testing, I would say engaging, because not only are we finding out about some of these genes and these changes that may benefit our population, but we may also benefit from getting the treatment that we link them to. And specifically, they found that African Americans were more susceptible to lung cancer. There are 2 specific mutations, don't have to remember that, but these mutations are so much higher in blacks than whites that there's a benefit, there's potential benefit if you get the testing and you're offered the treatment related to it. So we know the disparities for African Americans, and I mentioned this earlier. They're diagnosed at later stages. They wait longer or may not even receive the treatment for the cancers, and they have lower survival rates. It goes along the same lines for biomarker testing, okay? That only 14% of African American patients receive biomarker testing versus 26% of white patients in one of these trials. Okay? So both numbers are low. Both numbers are not acceptable, but we're basically half of what's happening with the rest of the population. And a lot of this is, when we think about healthcare disparities and how there are these disparities, part of it is the actual health care that's offered or received or accepted. And the other component is those which are related to the patient's biology, susceptibility to tobacco smoke, risk factors, family histories, those things which factor into these disparities. But what we do know, and we saw this from surgical treatments, right? If you have early stage lung cancer and the treatment of choice is surgery, when African Americans and other populations have equal treatment, you have a stage 1, you get surgery, you have a stage 1, you get surgery, that the outcomes are the same. So equal treatment gives equal outcomes. Okay. So what we need, what our responsibility is, get this message out. Equal treatments will get you equal outcomes. And that biomarker testing may do the same for those with late stage. So, who should have this testing? Who should have the testing where we're looking for these specific gene mutations so we can get specific treatments that are individualized for the patient? Okay. Well, it's those patients that are newly diagnosed. Okay. It can be those patients with, now that it's early stage and for late stage. We're now starting to test earlier. Even if you can go for surgery, we'll take that tissue and we'll still test it. Because what we do find is you get such a huge benefit of survival by having the surgery and having it removed from your body that you'll live longer. And when you live longer, you still have the risk factors, even in your past, for lung cancer. So you'll live long enough that maybe there'll be a recurrence or a new one pop up, right? And you can test those markers across the board. So for early stage, we're testing. For those patients that have metastatic disease where they can't get the best treatment, which would be surgery, that they have to get chemotherapy, we're actually testing for that to see if we can target something specific, because the new treatments might be a pill or once-a-month infusion that's not as harsh on the body as some radiation or the chemotherapy. And if after getting treatment the cancer comes back, you retest to see if it's mutated. Because the whole process of lung cancer starts with a mutation. It doesn't mean it stops mutating. And so you track that. Just like you can have resistant bacteria, you can have resistant cancer strains. And so we keep in mind that we focus on this, and it could benefit because we know African Americans have higher diagnosis rates and higher mortality rates, that maybe biomarker testing is the way to level the playing field. You like that sports reference there? Okay, got you. Okay. So how does biomarker testing help? Well, we identify those unique characteristics of lung cancer that you can target, whether it's stopping the lung cancer from building its own blood vessels, whether it's stopping that mutation which helps it spread and connect to other tissues, or whether it's stopping it from just thriving in the body. And we can use this to track the response to treatment. We can help with screening of the patients because they may not, now we can just check blood levels from it. It gives other diagnosis of what might be happening. We've seen patients that have 2 different types. You think it's the same, but they come from 2 different cell origins. They have different mutations. And now you can pick treatments which target those individually. Okay? And it helps track the response. And what they've seen is with these new therapies, there's better survival rates. Okay, it actually improves the survival if you can get the targeted therapy. One, because you may get an easier treatment than actually having the radiation or the chemotherapy. Hair falls out, kidney disease may limit what you can get. Liver disease may limit what you can get, or it may actually cause some of the problems. Okay, so we start to see that some of these new treatments have less side effects. And I put this up, and you don't have to memorize any of these, but what they're making a comparison of the different biomarkers that we can test and the percentage they show up, and each one of these can lead to a different type of treatment that's available. And they've listed the different therapies available, depending on which marker you may test positive for. In the past year and a half, there's about 35 new treatments, new targeted therapy for your individual lung cancer that's become available for patients. And this is the message that needs to get out. So, when you go to the doctors, if you happen to know somebody that has a diagnosis or you have the diagnosis, you need to ask them. There's some specific questions about biomarker testing to ask. And I have put together this little mnemonic, biomarker. I told you it's childproof. Okay, so your bio-M, okay? So biomarkers. One question to ask is, do you need biopsy for the additional testing? Sometimes they may have the tissue that they got when they made the initial diagnosis they can run it on. Sometimes they can do it from blood. If they need additional, it might be helpful to let them get additional biopsy for the testing. So B. Fine. Is the testing covered by insurance? And that's one of the big initiatives, meeting with some of these representatives around the different states and getting the bills passed so it is available. And I understand Kentucky was one of the leaders. Okay, I got to get that straight. Okay. So, and it is a question to ask, is it available and is it covered by insurance? And there are some companies that will do the testing, I can name off what, that if you don't have health insurance, it'll be free. So you have to ask these questions. Okay. Has biomarker testing been ordered, right? Because, you know, you can get, the blood testing, whatever else. Have you ordered it already? You know I have cancer. Have you ordered it already? And if not, why? And what's holding you up? Okay. If they don't have it available where you are, get a second opinion. Go somewhere else. Go to the center that would do it. Go see Dr. Morgan. They'll do the biomarkers, yes. All right. And will management be delayed? Right? And the answer to that really is, if you ask these questions in the beginning, you shouldn't really delay your treatment. So the sooner you ask the questions, the sooner you take control of your own disease process, the less delay you'll have. That's it.
Thank you very much, Dr. Flano. That was, as always, very, very interesting. While other people think about questions, are there circumstances where you can't do biomarker testing because of pre-existing other conditions, say even another cancer, or medications that someone may be on?
No, there's really not, because a lot of the biomarker testing can come off the tumor itself, and they can send that off, and you test specifically for what's being expressed on the tumor. Okay. So it's helpful in terms of when you have the cancer, when you have a diagnosis of cancer, it's there. There are a few tests that kind of are predictive. You can get blood work that'll help predict whether or not cancer is present or not. But if you've had a prior history of cancer, it sort of loses its ability to detect really well or differentiate if you have something new or if it's related to what you had before.
So if you would expound upon that just a tad bit more. We are aware of doing the so-called blood biopsy
Yes.
as a means for screening.
Mm-hmm.
So is that the same thing, different, or is this when you talk about some other conditions that may preclude doing blood testing?
It's kind of the same thing, and the reason I'm saying I'm not trying to is that there's several companies out there, and everybody has their different tests. So one of the ones that we use, that if you've had a prior history of cancer, it is so sensitive in detecting that if you had a prior history of cancer, it will still show up positive even though you may not. So it's you don't want to get a false positive or a false negative. The other thing that we're still trying to work out is when these tests are going to be useful in terms of screening. That's going to be a very large study that needs to get a lot of information and find out which test is going to be helpful for screening or not.
Finally, we talk about doing therapy based upon biomarker positivity. What is the difference in survival rates that we're seeing? If you would tell us about differences in survival rates and differences in terms of disease-free survival, so overall in disease-free survival. Are we really, are we talking small percentages, or are we talking really large numbers?
Some studies up to about 20%, right? So it's about 1 in 5 are having a better outcome. So that's useful. And And that's kind of what we call over the 5-year survival that they're tracking from that standpoint. What I've seen since we've started routinely doing the biomarker testing and had targeted therapy at our hospital, I mean, I've started seeing stage 4 lung cancer patients 5-6 years past their diagnosis. I mean, so those patients that get a response, it can be pretty dramatic. And if you even, and it's not always survival, it might be, you know, how much predicted lifespan it is increased. And if somebody, even though they may have stage 4, they live a year longer than they would have without, that's a year that they have with the rest of their family.
Because Dr. Williams made a point of saying that even after treatment, you still need to get now surveillance examinations.
Yeah.
I would presume that if you are able to detect markers in blood,
Yeah.
that they would be positive before a scan would be positive. Is that correct? And is this a means of now following this patient so we can pick up really early disease or early recurrence?
We're starting to see that, and that's, you know, depending on how sensitive the test is for detecting it, you're starting to see that you can pick up something before you might see something on an X-ray or a CAT scan. The consistency and variability is still pretty wide. And so, you know, your how sensitive your test is, how large the cancer has to be before it starts expressing a lot of these markers, still needs to be determined, and which test is going to outperform the other. Because what we're looking at here with all of these different treatments requires, you see that you require a lot of different tests. And so we're, you know, the more and more keep coming up, and it's just we haven't got one standard test which will tell you everything.
Do we have any other questions for Dr. Yes, sir.
It's more of a comment, but I think Dr. Williams and I looked over at each other halfway through your talk when you were kind of demanding of the physician, well, has it been ordered? You know,
Yes, yeah.
Is testing indicated? Has been ordered? And I think if I can speak on both our behalves a little bit, that's impressive, and that's okay, right? That's okay to push your providers and ask for what you need, but to be able to do that, you need to be informed, right?
Absolutely.
And that's where, you know, we all need to work better to have a little bit of background information, know the key steps of diagnosis, staging, treatment, what are the options, and know to ask those questions. So that was impressive.
I agree with you, and you'll see it because you said you do a lot of work with the with the Hispanic community, and you'll see that health equity will not come without health literacy, and the only way we can achieve that is if we as healthcare providers and we as that are now educated, support people, family members, whatever else, help educate those so that they know what to ask for, how to get there, and we won't ever reach health equity without health literacy.
Final question from Dr. Williams.
Great presentation. Thank you.
Thank
you. This question is on behalf of my 25-year-old daughter. As you were speaking, I sent her a picture of the slide that had the cannabis use. And the 50 uses as a heavy user. And her question is that 50 hits or is that 50 joints?
Yes. You tell her yes. Right. Because if I downplay it, okay, I'm good right now, right? And that's the problem. The problem is we recognize a lot of these things which are not doing very well for our population. We downplay it or we look aside to it because okay, it's easier to accept it, or get away with it. The reality is nobody starts smoking anything with the intent of saying, well, when I grow up, I want to be addictive and have lung disease and get lung cancer and be on oxygen and etc. Right? Nobody starts out that way. Oh, it's kind of fun. It's, I only do stuff when I'm stressed and whatever else. And we just kind of downplay it. And then over time, it becomes accepted. And the more it becomes accepted, the more it becomes ingrained and harder to quit. So you tell her yes and yes. Yeah.
Thank you very much, Doctor.
Thank you.
Thank you very much. Well, here in the great Commonwealth of Kentucky, we just approved medical or medicinal, whatever the heck that is, marijuana, without any studies to go along with it. And they haven't talked about what the delivery method is going to be yet, which is kind of interesting. Which, of course, the next thing after medicinal is just general approval for Dr. Williams' daughter to get high. I'm sorry, to get mellow. I'd like to turn the program back over to Representative Stan Watson.
That's a hard act to follow. Let's give all our speakers a hand right now. Thank you so much. And all the information that we have received today, I hope that you guys will take it and utilize it. One of the missions for HEAL Collaborative is to do, just like you said, health literacy is one of the things we try to do in the African American community. That's one of our missions and our goals to make it work. And we can only work with more captive audiences like our schools and especially our churches. And so again, we'd like to thank St. Stephen. Would you give them a hand as well? We'd like to thank the church, the staff, and our pastor, our HEAL Collaborative board and staff for coming today. And I thank Faith for doing an excellent job of putting this together. Give her a hand as well. Now, next Saturday, somebody say next Saturday, just like the preacher. Next Saturday, we'll be doing the policy piece of this. I think Dr. Williams and Dr. Morgan and even Dr. Tuxton had said, I forgot, get Dr. Tuxton a hand. He did an excellent job as moderator. But they talked about some of the things that we need in our community. I mean, she said something like sidewalks. I mean, just something simple. And we talked about white tablecloths earlier today and about health care and those kind of things. So we need to make sure next week, that we invite our neighbors and our church members to come back to this same facility so we can talk to our legislators and others about the policy piece of working. There was a tremendous amount of work done by HEAL and other organizations to make sure that our legislators here in Kentucky and all across the United States knew how important it was for biomarker testing to be passed as legislation to make sure that our patients, our caregivers, those persons that need it, could have this part of their care. And so I implore you again to come next Saturday. Make sure you're here next Saturday to talk to the policy piece. Before we leave, also, I want you to take care of the surveys that's inside your folders. Inside your folder, there should be a blue survey sheet. We need those as well, and you would give those to Faith or one of the members from our board of directors before you leave, and we'll make sure that it works for us. All hearts and minds clear? All right. There was a story in the Bible about Nehemiah rebuilding the wall. And each time he had put the people on the wall to do the work, there were some people called Sanballat and Tobias that wanted to break down the wall and try to break our strategy for building and rebuilding the wall and make sure that we had protection. So our mission, our goal today, and our clarion call for us today is that when the enemy attacks, we got to blow the clarion horn to make sure that we come out to our community to make sure that we have information that will make us better patients, make us better parishioners, and better persons of health. So we need to make sure we take care of that. And then lastly, I would be remiss as a deacon and a son of a preacher if I didn't say you can't just continue to be hearers of the word. You got to be doers as well. So I implore you in this community, St. Stephen's and here in Louisville, to come out and help us to be doers of the word and just not hearers only. We have lunch, so let's bow our heads for our prayer. Chris, thank you so much for coming with us today. Our Lord and Savior Jesus Christ, we thank you for this gathering today. We ask God that blessing upon the food. We even ask God that for those that are traveling, that you give us traveling grace and mercy. We ask God right now that you help us to be hearers, not just hearers of the word, but doers of the word as well, and that you will keep us in your care. Now, God, bless this food, the hand prepared it may be used for nourishing our bodies. Now unto him who's able to keep us from falling, and to present us faultless before his presence with exceedingly great joy, to the only wise God, our provider, Jesus Christ. It is in his name that we pray. Amen. Thank you. Lunch is served.